Thank you very much.
Thank you.
We'll move on to the next talk. Uh, yeah, Dr. Priyamvada. So she's going to talk about MOG optic neuritis.
A very good morning, one and all. I'm Dr. Harika Priyamvada, and I'm here to talk on MOG optic neuritis. I too have a disclaimer. I am also a pretty new neuro-ophthalmologist, and my aim of my presentation is to increase the awareness of MOG optic neuritis in non-neuro-ophthalmologists, because many asked me, what is MOG at all? So let's see what is MOG at all. MOG stands for myelin oligodendrocyte glycoprotein. As the name suggests, it's a surface transmembrane protein located on the myelin sheath. Antibodies to myelin sheath, antibodies to MOG can cause the myelin sheath to fall off, and it causes demyelination. IgG1 antibodies are the antibodies detected in the MOG disease, which activate the complement pathway, and the complement deposition is seen on neuroimaging studies. How are these antibodies produced at all? Mainly by the autoimmune mechanism, since it's an autoimmune disease, but some studies say a precipitating attack like fever can also induce production of IgG1 antibodies, which cross the blood-brain barrier and cause an optic neuritis. So, MOG optic neuritis is an antibody-mediated autoimmune demyelinating disease of the CNS with a spectrum called MOG spectrum. It is a very distinct entity from the other demyelinating processes such as multiple sclerosis optic neuritis and NMO optic neuritis. Acute unilateral or bilateral, being steroid responsive, recurrent episodes of optic neuritis are hallmark of MOG optic neuritis. What does the spectrum consist of? The MOG consists of optic neuritis, encephalitis with brain demyelinating lesions with or without myelitis. Hence the term monim or MOGOD is used. But optic neuritis has been reported to be the most common presentation and manifestation of MOG spectrum disorder. So how do we differentiate between typical optic neuritis, that is MS optic neuritis, and the MOG or the atypical optic neuritis? Typical optic neuritis patients are usually present with unilateral, more female preponderance with variable visual acuity and visual field loss. They usually present with retrobulbar pain and a normal fundus, that is the retrobulbar optic neuritis. But MOG optic neuritis patients are usually present with bilateral rather than unilateral, or unilateral can also be present. According to our recent research, we found unilateral presentation causes more recurrences in MOG optic neuritis. There is no gender predilection, or some studies say males have a preponderance of MOG, and it is mostly associated with optic disc edema rather than the retrobulbar optic neuritis. The acute vision loss ranges from around 20/40 to counting fingers or even PL negative, but the prognosis is very good that after treatment they improve to 20/20 also within a month. So the loss of color vision, RAPD, are similar in both the conditions. Why are we talking on MOG at all today? Because according to ONTT trial and the Western data, the prevalence and incidence of the multiple sclerosis is more, but after the era of biomarkers, the incidence and prevalence has changed, especially in India and Asian countries. The prevalence of MOG is 28%. So the clinical features are, children and young adults can be affected, and any age group can be involved with acute vision loss. Bilateral most common, and can be unilateral or recurrent in the other eye, or which we call as sequential. With they can present with papillitis. They have excellent response to steroids, recurrent episodes, and they are associated with myelitis and encephalitis. So they may have associated seizures, dysarthria, encephalopathy, and limb weakness. So ADEM-like features can be present more commonly in children. So MOG is increasingly recognized in the pediatric population, and suspect MOG in case of new onset of seizures or sudden regression of milestones. We have cases or instances where we have seen children presenting with vision loss and encephalitis together, where vision loss is just ignored. ignored, and encephalitis is completely evaluated for everything including Lyme disease. But later on, when they presented to us after 3 or 4 months, we did a MOG test and the MOG is positive. So MOG is such important, especially in the pediatric patients. Children from 1.5 years can also be affected. So how do they present? They present with grade 1 to grade 4 papilledema, any grade of papilledema, or they can present with temporal pallor or disc pallor in the other eye, especially in recurrent cases. So HVF, according to ONTT, any type of field defect can be present. Similarly, in MOG also any type of field defect can be present. In acute presentation with a higher grade of vision loss like counting fingers and all, they present with advanced field loss. On OCT, we look for disc edema and RNFL thickness above more than 125 is considered as true edema. And on MGCL, that means ganglion cell thickness, in the initial presentations it could be normal, especially in the first episodes, but most of the patients presents with a thinning of ganglion cell layer, and the GCL thickness is very low, less than 80. On OCT angiography, there can be a rare fraction of peripapillary capillary density in left eye. In the affected eye. MRI findings, let's see what is a normal MRI at all. Sir, can I continue, sir?
Yeah, you still have.
Okay, so this is a normal MRI showing a T1 image with the optic nerve and fat around. This is can you see the pointer? Yeah. The T2, this is a T2 image, the axial sections showing the normal optic nerve and the CSF, normal CSF fluid around the optic nerve. This is a fat suppressed T2 image. This is again a T1 image which is with fat suppression. Okay, this is the coronal image. Just observe the color difference between the optic nerve and the muscles, because that is important. I am going to tell. This is the whole optic nerve this is the intraorbital part, this is the intracanalicular part, intracranial part, and the intracranial part. This is the chiasma. This is just the tactography. So what will we see on MOG optic neuritis? We do see hyperintensities of optic nerve on T2 weighted fat saturation images. This is the T2 weighted fat saturation images with long segment involvement of the optic nerve and have hyperintensities. These are confirmed by the enhancement of the optic nerves on T1 contrast imaging with the gadolinium. Fat stranding is also specific for the MOG disease, and optic perineuritis is also specific for MOG disease. So yeah, this is the similar depiction of long segment involvement and the perineuritis involvement. MRI brain non-specific white matter demyelinating lesions are more common. Normal MRI is also common. MRI spine, there could be a swelling of spinal cord and contrast enhancement similar to transverse myelitis findings. These are our patients presenting to us with a thoracic lesion in the spine, and involvement of conus medullaris is most common in MOG. So you can take a picture of this, which differentiates the features of MOGAD, NMO, and MS. So how do we diagnose the serum analysis? We do a serum analysis. Cell-based immunofluorescent assays are often preferred as it is more sensitive and specific and the current gold standard for diagnosis. It is very recently, it is the MOG antibody detection has been started only or discovered in only 2007, and hence it is very new and is less available in the smaller cities especially. Contrary to the seropositive aquaporin 4 serum antibodies coexisting in ant MOG syndromes, only 9 related autoimmune conditions are found in over 1/3 of aquaporin 4 IG seropositive NMO cases, but only in 9% of anti-MOG syndromes.
Can you
Treatment
wind up?
IV.
Can you wind up?
Yes, ma'am. Treatment, we give IV methylprednisolone for 5 days, and for maintenance we give azathioprine, MMF, and rituximab. So it has good prognosis, and the differential diagnosis are NaION is also an important differential diagnosis. So yeah, this review article confirms the data is different from in India from the West. Thank you.
Thank you. That was great. And I know it is short of time, but it is an extensive topic, and I think it's very important. And especially in our population, the awareness of MOG optic neuritis definitely needs to be disseminated.
Sorry for taking more time, ma'am, and I thank AIOS for giving me this golden opportunity to talk in front of legendary neuro-ophthalmologists. And thank you
There
for
are
your
no
kind
legendary
intention.
neuro-ophthalmologists. We are all
So-
still in the process of learning and acquiring. Neuro-ophthalmology is a very nascent and
So
young
what is
specialty.
Yeah.
And I'll just take this opportunity to invite all of you. We are holding the annual Indian Neuro-Ophthalmology Society meeting at Hyderabad on the 9th and 10th of December. That will be a place where all young and old, not necessarily experienced neuro-ophthalmologists will be coming together, and we have a host of international faculty to give us some insights into this emerging understanding of a very complicated disorder that requires, I guess, understanding from all of us. So thank you, Dr. Priyamvada.